Welcome everyone to the Society of Thoracic Surgeons. Today is today's Wednesday, October the 19th, and we are here for the General Thoracic Surgery Database new data manager webinar. So welcome to all of our new data managers, and welcome to some of those if you're returning or have been a data manager for a year or so or longer. We welcome you guys here as well. So let's go ahead and get started. On the call today, you've got the full attention of myself, Leanne Jones, and Ruth Rowley. So it's just the two of us today. So you've got our complete and undivided attention. So we welcome all of your questions. So let's go ahead and kick things off. In terms of the agenda, I am going to handle the introduction to the STS and the databases, and then I'm going to turn everything over to Ruth. Ruth is our GTSD consultant, and she's going to handle the remainder of today's presentation. And then after today's presentation, again, we'll turn things over to you all for questions. Please be sure to submit your questions via the Q&A function. And please not the chat. So again, please submit your questions via the Q&A. If you'd like to raise your hand to ask a question, you are more than welcome to do so. Just please be sure that your microphone is enabled. So I'll unmute you on my end, but just also make sure your microphone is enabled so we can hear you if you have a question. So again, we do encourage you to use that raise hand function if need be. So in terms of the agenda today, I'm going to again cover the introduction to STS and the databases. And then, as I stated, I'll turn things over to Ruth, and Ruth is going to touch on the role of the data manager, how to read the data collection form, go over required fields, give an introduction to the data specifications, intro to the training manual, how to submit an FAQ, keys to abstracting data. She'll go over building relationship with your surgeon, how to ensure your data is ensuring clean data. We'll review data submission deadlines, and then we'll touch on any additional STS resources. Also, again, if there's something that we don't cover in this webinar, please feel free to ask your questions afterwards. We encourage back and forth. So please just, bring any and all of your questions to us, and we'll answer as many questions as we can today. So just be sure to go ahead and get your questions ready. We're here for you. All right, just to introduce the STS staff, Donna McDonald is the Vice President of Quality. Also, we have Jane Hahn, who is the Vice President of Quality and Research Operations. Carol Crone, many of you have heard her on the webinars with me. Carol is the Director of the STS National Databases. So she is the Director over all three databases. I know cardiac, congenital, and general thoracic. So she is the director. Catherine Holyfield is the database manager for the Intermax and PDMax databases. And then again, myself, I am the database manager for general thoracic and the congenital databases. We also have Emily Conrad. I'm sure you guys have heard Emily's been on several of our webinars recently as she handles the upcoming AQO, and Emily is our STS National Database and Patient Safety Manager. Derek Steck, I'm sure many of you have worked with him directly. Derek is our Senior Manager for STS National Database Contracts. So again, Derek handles all things participation agreements. So if you have questions about your contract with STS, Derek is your point person. Sydney Clinton is our Quality and Database Operations Manager. Sydney handles STS public reporting. So if you have any public reporting related questions, Sydney is your go-to person for STS public reporting. We also have Banu Yagasi, and I pray I say her last name right. If not, Banu, forgive me. Banu is our Quality Measures Manager. Addie Dolan is our Quality Programs Operations Manager. Addie handles all of our STS participant contact information. So if you are updating contacts, have questions about contacts, in addition to many, many other things, Addie keeps us straight there and handles all of those contact updates. And then we also have here our amazing GTSD consultant, core group member, Ruth Rowley. I could not do this job without Ruth, and Ruth is out of Trinity Health. So thank you, Ruth, for all that you do. I appreciate you more than you will ever know. All right, let me hold on, I'm sorry. Let me get my other information up, so apologize. All right, so a brief introduction to STS and the databases. The Society of Thoracic Surgeons was founded in 1964, and our mission is to enhance the ability of cardiothoracic surgeons to provide the highest quality care through education, research, and advocacy. Today, we have more than 7,500 members in 99 countries. The STS itself has more than 65 employees in Chicago and DC. The first database was started in 1989 as an initiative for quality improvement and patient safety among cardiothoracic surgeons. And this was basically in direct response to Health and Human Services, also obviously now known as CMS. It was also in direct relation to many malpractice lawsuits that were happening related to a misperception of the risk associated with our cardiothoracic surgeries. Also, as a Joint Commission's requirement of health systems to have a quality assurance program used for surgeon re-credentialing is also the database was founded also due to many of the threats due to surgeon reimbursement. So, all right. The STS database has accomplished many things over the years. Just wanted to highlight a few of those. The STS national databases have improved patient outcomes and patient safety. We've helped develop clinical practice guidelines, specifically on blood conservation and antibiotic usage. And also our voluntary public reporting initiative. It has been shown, it's proven that sites who publicly report do tend to have better outcomes. The General Thoracic Surgery database started in 2003, and today we have more than 880 surgeons at 279 national and international sites. Right now we only have one international site, and that site is out in UAE. And of those 279 sites, approximately 43% of our sites are participating in general thoracic public reporting. We hope to obviously get that number higher as we move forward. Also the General Thoracic Surgery database does contain more than 719,000 records for more than 612,000 patients. So that's just a brief introduction of the STS and the databases. And with that, I'm going to turn things over to Ruth so she can present the rest of the presentation. Ruth?
Thank you for the glowing introduction, Leanne. I appreciate you as well. Great partnership with the STS. So we're going to jump into now the data abstractor, data manager role. So the role of the abstractor is to abstract the data, but also the data has to be cleaned and then submitted to the STS. Also, data managers are often involved in quality improvement projects. One of the talks at the AQO is going to be specifically about quality improvement projects that sites are participating in. There is a role in chart review, perhaps, depending on your location, best practices. So looking at ways that the data can be used to shape practice at your institutions, improving workflows on units or within the OR, improving teamwork. So looking at things like handoffs are very high risk events. So that's often where mistakes in patient care can happen. And so you might notice as you're reviewing these charts that there is an opportunity to improve teamwork. QA meetings with your surgeons and your supporting departments. So things like morbidity and mortality conferences, M&Ms, or other meetings within quality departments at your sites. If you are not involved with quality at your institutions, I strongly encourage you to reach out to the leaders for your quality department or institutions and see how you can get involved. And then also There will be some administrative reporting likely on star ratings that needs to happen. So really developing those presentations potentially that allow your surgeons to highlight what the STS data does for patients and does for the hospitals, and getting that in front of executives so they can recognize the value add of the database. So data collection organization is extremely important. So you have to identify the who, the what, and the when of data collection. So identifying your surgical cases is very important. Which cases you're going to include, knowing which fields you need to collect for which cases, and then deciding when you want to collect the data that must be collected. So the first step, identification of your surgical population. So understand what your gold standard source is. Make sure that it's reliable and it's reproducible from day to day, hour to hour, month to month. So different sites use things like an OR log or a report that's built out of their EMR. At my institution, what we do is we have the physician assistants who assist with every case, keep an Excel spreadsheet log, and then every patient has a rounding card. We use a combination of those to make sure, so this is the next step, the double check. I match every single patient's data card that the PA creates against the surgical work list that the PA creates. And if there's a patient that's on one and not the other, then we reconcile those differences. Things might change over time. So you might start with using a certain source for your identification of your surgical population, and then a new tool may become available and you might shift what tool is the best tool for your site, and that's perfectly acceptable. But if you do get audited, you will need to be able to provide to the auditors a list of all of your surgical cases so that they can either agree or disagree with you on what cases you chose to select based on the STS standards. The next section is understanding what data needs to be collected. So identify a source for all fields. Again, this needs to be reliable and reproducible. You can use EHR documentation, or if your site is slick enough to have developed some reports for you that allow you to fill data fields based on information contained in the EHR without you having to click through every document, that's also acceptable. The data comes ultimately from the EHR. You have to use the training manual for guidance on your definitions. I know that some vendor software will include definitions. The tough part about relying 100% on what is built into your vendor software is that some software will include the definition, but not necessarily the intent or clarification. And I don't know that any of the vendors include FAQs for sequences that may make a significant difference on what data needs to be input for a field. So the training manual is really where you want to look when you're abstracting data to understand what needs to go into each field, and you need to keep up with FAQs and updates as they come through. The next, oh, go ahead, you're fine. The next one, so when to perform the data abstraction is going to depend on resources, volume, what EHR you have, what data you need. So some sites do real-time data collection. So you could potentially enter some data the day of the patient surgery, or really even before the patient has surgery, I suppose. Some sites collect data after the patient is discharged. And then some sites, like my site, we wait until 30 days post-op to enter any data, just because it's more efficient for us to look at each patient once than it is to abstract data and then come back and abstract data again. You can do a combination. There are really no rules around what, when you have to collect the data. You just have to include all of the cases for a particular harvest period before the harvest closes. I guess that is a rule. So maybe not no rules, one rule. There's one rule. The next slide. So looking at the data collection form, if you want to go to the next one. Oh, I guess go back. Sorry, I lied. So
I can pull over the data collection form if you want me to.
We can sort of see it here.
Okay.
So you can see that there are fields that are underlined in blue and they have the little double red stars next to them. Those are mandatory fields. The only exception to this currently is ECOG, which I believe on the data collection form is still underlined in blue, but as we all hopefully know at this point, ECOG is not required to submit a case. Otherwise, if you don't include the required fields, you will get alerted that you're missing information. And you can see the short names for the sequences and the sequence numbers are there in red, which is helpful if you need to search in the training manual for a specific sequence to get more information. I think searching by sequence number is the easiest, fastest way.
Right. And this also, I'm sorry, I just wanted to, this is also, just because I've had a couple of people reach out to me, the newer data manager is submitting an FAQ, and I think you'll cover this down the road in addition, but these are the sequence number and the short name that's referred to when you're submitting a clinical question via the FAQs.
Okay, so what procedures have to be included? So for version 5.2.1.1, you have to submit all lung resections for new primary lung cancers and all esophageal resections for new primary esophageal cancers. The rest, and those both are risk adjusted. You get star ratings for both of those. You can get, if you abstract, you will get benchmarked data for thymus and mediastinal mass, tracheal resections, and hiatal hernia GERD. And to be more specific, I guess I should be more specific on thymus. They're looking for thymectomy for thymoma specifically and myasthenia gravis cases, not all mediastinal mass resections. The rest of the cases, your site can enter if they choose. There is not a short form. So previously, if you've talked to data managers that have been doing this for a long time, there used to be different forms for cases that were going to be analyzed or benchmarked versus others. And that went away with this version. So you just would complete the same form for all of the cases you enter. I would be thoughtful and really understand what your surgeons are looking for. If they have you abstract all of the cases, it's a significant time commitment. And if they're not asking you to produce reports for them based on the data that you're abstracting, I would think about how you could add value to the organization by either starting to create reports for that data that you're collecting or, really digging into it if you're going to take the time to collect it. Everybody wants to feel like the work that they do is valuable. And I think it's really easy to see how the lung and esophageal cancer resection data adds value and those benchmarked reports. A little bit tougher for things like decortication if your site isn't using the data. So help your surgeons brainstorm and think of ways to use that data if they really want you to collect that data. Concomitant procedures are procedures that are done at the same time as an analyzed procedure. And you just include it on that same form. So for example, if your surgeon did a lobectomy with, I don't know, a lymphadenectomy or whatever, the lymphadenectomy is done at the same time and it would be captured on that form. I'm gonna go to the next one. So which variables are required? So all variables are important. There are parent-child relationships that are built into the form. So, for the cases, like if you were going to decide at your site that you're going to collect decortications, if you put that in there, you're going to answer no to all of the esophageal cancer, lung cancer, mediastinal mass. None of those sections will open up, which reduces the amount of data that you have to input. The STS tried to be very thoughtful about minimizing the number of fields that people are required to abstract. But if you are required to abstract a field based on a parent-child relationship, please do enter that data. It's extremely important that you do not omit any of the fields that are required. So this is the mortality variables. I covered those in the webinar last week, I think that was, that MT 30-day status, and even what's the name of the other one, Leanne? MT 30-day stat and discharge, mortality at discharge.
Yeah, mortality at discharge.
I can't think of the short name of it, but that's what it is.
MTDC stat.
Yes, MTDC stat, thank you. So both of those are the mortality variables that have to be entered. And then, like we said, the required variables, which are underlined in blue on the form for you. And then the risk model variables. So what you might be wondering now is, how do I figure out what the risk model variables are? So the risk model variables, the best place I think to find those is in the IQVIA library. Hopefully I'll be able to show it to you in a minute. Mm-hmm. Complete all your fields consistently so they're meaningful internally and over time. So the best way that I've found to do that is to keep up a source document. And I think those have been shared. Are they available on the STS website, Leanne?
Which the
source documents for examples of source documents from other sites. Before. It's so essentially what I did was I created an Excel spreadsheet and I said, for this field, I look here as my primary source. If it's not there, I look here. So
let me follow up with
the start times, for example, should come from the anesthesia report. But if for some reason the anesthesiologist didn't include it there is another report available in my EMR where I can find that data. And that's my secondary resource. Things like medical smoking history. So I always take my smoking history from the same place. As you know, smoking histories are all sorts of different. They're different every place you look in the EMR. And so if I got audited, I wanted to be able to say, well, this is why I entered this one. And it's because my primary source is my surgeon's H&P. My secondary source is the socio, like the SES report in Epic, and whatever is entered there is my secondary source. And the data that I don't use is, the anesthesia note is not where I take my smoking history from. That way it's very clear where I got each and every data piece. And I think in the past, the STS has shared examples that different sites have shared with them. Okay, so again, this is required variables for case inclusion. They're underlined in blue. They have to be included. And again, the only exception to this is ECOG, which is clearly documented in the training manual. One of the things that was new for this version was the weighting system. So you'll see on the data collection form underneath each section, there is a weight. The weights are intended to designate what your primary procedure should be. So the issue that we were having was that patients, or that data was being abstracted in the order that it was listed on the operative note. And the way that the STS processes the data is, it's very important that the primary procedure, the first thing you list, is the quote unquote sort of biggest part of your surgery. Like, why was the patient in the OR? So if you have a patient that has a lobectomy with a lymphadenectomy with a diagnostic bronchoscopy and, I don't know, throw in whatever else you want. The lobectomy is the lung cancer resection. It has a weight of 60, and it's your primary procedure because it has the highest weight. If you had a patient that had an esophageal resection at the same time as a lung cancer resection, the esophageal resection has a higher weight. It would be your primary procedure. That would be an exceptionally rare case. And then things like the concomitant procedures, which are often performed in addition to one of the other procedures, have a lower weight because they should not be your primary procedure in any instance. The database gets updated every 3 years. The specifications are key for that process. So it's important to understand what the definition for each field is, what values are allowed, and then parent-child relationships. The vendors build their software based on the specifications that are provided to them by the STS. So one of the things that recently came up was, I think it was DLCO percent of predicted or FEV1, I can't remember which, but if you look at the data specifications, it's defined by the STS that it has to be an integer, and integer is by definition a whole number. But one of the vendor softwares had built it allowing decimals. And so that was creating problems on the data manager side because we hadn't defined what to do with decimal values when they get input, because we had indicated to vendors not to allow the decimals to go in. So then that site didn't know, how that data was processed on the back end since it didn't meet the specifications that were set up front. So looking through these is really important. It's a critical component of the data manager role is reading through these definitions and really understanding them. Sometimes my surgeons will say, well, that's not what a blah, blah, blah is. And I pull out the training manual and we read through it and they'll either say one of two things like, oh yeah, I get that. Or, well, that's dumb, but it is what it is, right? So they sometimes disagree with how the STS has defined something, but they understand that the definition is what the definition is and that it's true for all sites. And that's what makes the database work, is that it's true for all sites. So we're all on a level playing field, which is really important. Allowable values. So for this example, it's hemoglobin. So the allowable values fall between 3 and 50. If your value is below 3, it will not allow you to enter that value. You have to input a value that is allowed. You'll get a warning when they think you might have made a typo, right? So where I get this a lot is lymph nodes harvested. My surgeons tend to harvest a lot of lymph nodes, so I'll often get a warning that says, are you sure? Did you really mean that many? And I always validate that data point and then proceed if I haven't made an error. And all of the allowable values are listed in the training manual, just like it shows on the right-hand side here. So every numerical value has highs and lows and what's allowed to be entered. And they'll tell you what format it has to be entered in and how many decimal places are allowed, et cetera. The training manual. So this is where you should look when you have a question about how to abstract a variable. Sometimes I'll get FAQs and the answer is in the training manual, which is fine. I know that it's easy to forget to go back and look at the training manual, but I try to remind people when I get those questions that the answer is right there, because I know that everybody likes to get their cases entered quickly. And the quickest way to get a case entered is if everything that you need is right in front of you. We provide intent and clarification information to further explain definitions. We update the training manual every month with FAQs. And again, always check here first if you have a question. There's an FAQ summary document. We talked about this at the last webinar. The FAQ summary document just helps you know what sequences have been updated for the month. My strong preference and strong suggestion to you is to look at these in the context of the training manual. Sometimes the FAQs will reference information that's either above or, well, generally above the update. And so you'll need to understand it in the context of the entire training manual. But it's helpful to just have a quick list sometimes. So we provide this FAQ summary, and this is new. We just started doing this for GTSD with this version. Prior to this version, there was not a summary document. Clinical questions can be submitted online to the FAQ mailbox from the STS website. You need to include your participant ID, please double check that your email address is correct so that you get your response when I send it to you. I cannot open information that is sent to me as a secure link. There should be no PHI in your request, your FAQs, your questions. All the PHI should be removed. So nothing should need to be sent secured. If something, I know that email systems sometimes automatically secure documents, which can be very frustrating. So I'll just send an email back to you that says I couldn't open it because it was secured. And then you can try to send again. Sometimes it takes 30 days or even a little bit longer to get a response. So the cadence of the meetings is that the core group meets every 30 days. Sometimes there are questions that I take to the core group, which is a group of data managers and then 3 surgeons, and they can't come to a consensus. When they can't come to a consensus, then the questions are taken to the task force, which is a group of just surgeons that will talk through the question to see if they can come to consensus. Sometimes they cannot. And then a subgroup is formed to further, look at data that would potentially help the group reach consensus. So sometimes it will take longer than 30 days. I try to provide updates if your issue has been taken to the task force, just so that you know it's going to be a little bit longer. Once they take it to a subgroup, it's hard for me to really outline for you how long it's going to take. Fortunately, those issues are few and far between, and overwhelmingly, the majority of issues are resolved within 30 days. This is what that form looks like. And again, include all of the information and double, triple check that you have a correct email in there. And also be sure to send it to the right database version. The FAQ inbox is automated to some extent. So if you send it to, congenital heart or wherever, it will eventually get to me, but it delays the process pretty significantly sometimes. So keys to abstraction: be consistent where you get information, pay attention to your source documents, use data that meets the requirements. If you are having a hard time finding something, please ask your surgeons. Don't guess. No data is better than bad data, which I think is what we're seeing with ECOG right now, which is a little bit painful, but I think we're going to get to the place where we have that documentation from surgeons. And I think that's some of the quick keys there. Working with your surgeons. So surgeons are busy. Be patient and persistent though. Be clear about what you need. Understand, so do your homework, know the facts, understand what the training manual says about the question that you're bringing to them. They all have their own definitions in their mind about what you are asking for. So if you say, did this patient have a surgical or sepsis, I think is a great example. So sepsis is defined as requiring a positive blood culture. If you ask if your patient has sepsis, they might say yes, the patient might not have a positive blood culture. And then you aren't abstracting data correctly. So understand what how the training manual defines the metric that you're asking your surgeon about before you have that conversation. Ask to go to the OR with your surgeons. Overwhelmingly, surgeons love having their data managers be interested in what they do day to day. And it's a great way to learn about the procedures and about what goes into both preoperative and postoperative care for patients. Offer to review the data with your surgeon. I would see if you can set up routine meetings with them, find their days that they're not in clinic, and really utilize that time to maximize the value that both your site and the STS are getting out of the data that you're spending so much time very carefully collecting. Offer tips on how documentation can be improved. So work with your surgeons on building templates into the EHR. So one of the things that there's been so many over the years, but as database versions change, new data points get added. One of the things that I had a really hard time finding was a hiatal hernia type, whether it was 1, 2, 3, or whatnot. So I let my surgeons know, and they kindly started adding it to the operative note, like in the procedure. Like they would tell me what type of hernia it was, because it's easier for them to do that up front than it is for me to circle back with them every time I had a hernia case that I couldn't quite figure out. Work with your nursing and your OR staff, they can help you. So for example, one of the things that my site does, we have physician assistants who round on all of the patients. The physician assistants have cards where they collect data. There are certain data points that I define in my sort of reference list for audit purposes and just for data consistency that come from that physician assistant card. The auditors were happy to see that I use that data. They were happy to take that as a source. And it really allows us to consistently get good information about patients. So things like, functional status at home or discharge with HOMO2, I can get a lot of that data off of that card that we collaborate with the physician assistants to generate that documentation for us. Your vendor will allow you to run checks on your data prior to submission. I love my vendor reports that they create for me. I think it's a really helpful tool for making sure that we have clean data before we even upload it, which is helpful. IQVIA also provides you with data quality reports, the harvest summary report, the critical error report. Use all of those tools to make sure that you have good data that's been sent to the data warehouse so that there are no surprises. There should be no surprises when you get your harvest report back. You should have an understanding of what you will be seeing in terms of case inclusion. There are also on-save consistency checks that are built into vendor software that prevent you from exporting data if there are errors, which should hopefully be helpful to you. The harvest submission deadlines are twice a year for general thoracic, spring and fall. Both reports get a star rating. There is voluntary public reporting as well, which is based on the spring harvest. If you are interested in publicly reporting your data and are not currently, I believe the form to participate in that is available on the STS website.
Yeah.
And the harvest submission deadlines are also listed on the STS website, and we can hop over there at the end of the presentation and walk through a couple of these things for you.
Perfect.
Other resources that the STS provides. So there's the monthly webinar where we go over updates to the training manual and other things that we've learned. Like last week, we talked about a lot of things that Harris, the STS statistician, had noticed when he looked at the harvest file. So hopefully that was a helpful learning opportunity for everyone. There are also user group calls, which are intended to be more focused on IQVIA issues or technical issues that have arisen in the last month. We also do the new data webinar, manager webinar. These are all saved and they are available on the STS website, and we can show you where those are so you can go back and watch any of them. I know that Katie Lothrop did a wonderful presentation on going through the harvest report. Again, that's saved and it's on the STS website, and you can go and watch it at any time, which I think is great because calendars are busy, and it's nice to be able to just use those resources whenever it works for you. AQO is Advances in Quality and Outcomes. It's the data managers meeting. It's coming up next. Is that next week?
It's next week, yes.
I can't even believe it. Where's the year gone?
So I know, next week, this time we'll be in Providence.
Nice.
Doing visitors, yeah. We'll be, yep.
AQO is a tremendous opportunity. If you have not been, I highly encourage you to go. You will learn so much. There's an opportunity to ask questions. You earn CEUs. It's nice to connect with other data managers. It's nice to hear what other data managers are doing with their data. it's just, I cannot recommend it enough. There is a virtual component to it now, which is new since COVID. COVID gifted us with a virtual component for the meeting, which I think is great as well. It allows people who aren't able to travel to also glean a lot of the information from the meeting. And so now, before we jump into open discussion, do you want to go to the website quick? I know we don't have tons of time, so what do you think, Leanne?
Yep, I can pull over the website. I still can't get the IQVIA platform to show. Let me try one more time. Yeah, I can't, I don't know why it's not, it's something on my end, so I apologize. But the STS website, from the STS homepage, click on registries, registries STS National Database, and this will bring you to our homepage. For the databases, you have the links for adult cardiac, general thoracic, congenital. Also here, the buttons here. One of the top questions that we get is, need to update our contacts, things like that for our site. So I just wanted to show you where the participant contact form is located. All of your contacts need to be updated via the STS participant contact form. So from this main page, from the STS National Database page, if you just scroll down all the way down here to important resources, you'll see link here for database forms. The form is kind of hidden, so it's located under database forms. You click here, and this will bring you to our participant contact form, as well as a link for the Schedule A and Schedule B. So you just click on participant contact form, that'll bring you here, and you can complete the information on the form. Also on this main page, you can find all the other information regarding our live webinars. You can view webinars here. You can view past GTSD webinars by clicking here. Here is our session from last week on the 12th that Ruth was referring to earlier. We do record all of our webinars and post them out here on the STS website and the STS YouTube page. And a slide deck of each of the webinars is also included on this page here. So you have a recording of the webinar as well as the slide deck that was used for the presentation. Some other important information on the STS National Database homepage. There's also information on obviously joining the database. STS Composite, our composite measure series videos can be found here. As Ruth stated, for clinical questions, for submitting an FAQ, you'll find the link here to submit your clinical question. Also under database important resources, there are links to the harvest schedule and information. Carol and I are working on the spring and fall harvest schedule for 2023. So as soon as we have that completed, that information will be posted here. It'll follow the same around the same time frames that it fell in last year 2022. The spring 23 harvest close will be around the 1st of March, and same for the fall, it'll be around the 1st of September. So we'll have this 2023 harvest close dates posted here soon, and of course we'll let you all know on upcoming webinars when that information is available. We'll also include it in database news and things like that as well. Anything else you wanted to point out, Ruth? I know we've got some questions, so let's go ahead and jump over to our questions. Let's see here. Our first question from Linda. She's wanting the physician worksheets.
I know, it's my fault. I'm sorry.
It's okay. It's a lot going on. So as soon as we get those available, Linda will get those out and posted on the website, and we'll notify you once as well, once those are posted for the webinar. So we'll get those posted as quickly as possible. So, all right. How can you, our next question from Dion. So how can you abstract data when the primary source information conflicts with the secondary, which is sometimes information submitted by the patient?
You will just identify what your primary source is, and that is your primary source. So for something like smoking history, where the patient often provides conflicting information, I think the patient reports different things to different people at different times. And so even though it's all patient reported data, it's going to have different information. You just need to decide what your primary source is going to be and go with it. There are some instances where the STS provides some guidance on what the primary source of information should be. For example, things like your pathological stage, your primary source should be your pathology report. So if your surgeon or somebody dictates something different in a note, your pathology should come from your pathology report. You would either need to request an addendum of your pathology report if it was incorrect, and that's why there's discrepancy, or sort of dig into it some more. But it's okay to just say what your primary source is going to be and to go with it.
Okay. Our next question, is there a recent survey of data managers that shows us the average number of hours used for abstraction per case type, cancer, hernia, etc.? Would be nice. I think we have the 2022 data manager survey. The most recent survey that we have posted, it's out on the STS website. So if you go under the STS National Database homepage, I believe it's down here under Data Manager Education. If you click here, actually 2020 is the most recent. So if you scroll down here, the Data Manager Education, we have the results from 2020. I think we should probably need to get another updated survey out there. So we'll work on that. We'll plan on doing an updated Data Manager survey, but this is the most recent one that we have posted out on the STS website. But we can definitely do a recent one and get that posted. I'll add that to our list. So Ruth, do you have a PDF of that card that you referenced that you would be willing to share with the group?
Sure, I can just give it to you and you can post it somewhere if that works for you.
Okay.
Distribute it via email. I don't know what the best way is, but
yeah, if you want to send me a PDF, I can take it from this end. And if you, it might be easier if you just shoot me an email, Donna, and I can send you that PDF. All right. So from Nikolai, working with your surgeons, when it comes to audits, do HR templates count as an original source? My concern is that the surgeon or surgical team might put the wrong value there, say highest or lowest temp, but the correct value is the rented chart. We don't want to do double work.
I don't know if Carol wants to comment from an audit perspective.
Yeah, I can take this one.
Okay.
Well, first, I think if you have discrepancies within your documentation, you need to work internally to resolve those discrepancies and make sure that the correct documentation is listed in both places where you're collecting it. We will use EHR templates for the audit as long as they're scanned into the, as long as they're scanned in. Well, EHR templates, that would be something like a form with an Epic, one of those, what are they called, Ruth? Canned forms with an Epic.
Yeah, I think
so. If you're using if you're using a canned form with an Epic, or you have one built for collecting data, we would definitely be able to use that. I would, for when you're talking about the surgeon putting in values or surgical team putting in values, temperature are things that, you know, if your perfusionist, if you're pulling temperatures from perfusion, I know this is general thoracic, so perfusion doesn't necessarily apply, but say anesthesia is documenting temperatures. Those may be things that you can automatically pull over into your templates. So you wouldn't have discrepancies throughout your medical record. You can't pull them in over into your into the database, but you could pull them over within your EHRs into various spots to fill the template documents. So I think that that's probably definitely could use the forms as long as they're in the EHRs. Canned templates, canned forms are good to use. You usually can integrate or pull over values into those forms from other places within your EHR. And I think that's all I have. Do you have any other comments, Ruth or Leanne?
No, Nikolai was just saying that the Epic was referring to them as smart forms.
Yeah, canned forms or smart forms. I think you could, they're referred to as both within Epic.
I think that's Carol. So it's in reference to that PA card that you were referring to, assisting with data collection within the EMR and available to support an audit.
So
Yeah.
we don't scan them into the EMR, but they are available for an audit. So we save it's similar to a surgeon worksheet concept, right? Where you're asking someone to fill out a sheet that you save. So we save our PA cards for 7 years. And so if I've been audited, and I just made photocopies and I provided them to the auditors, and then I provided them a copy of my Excel spreadsheet that told them which data points that I took specifically from my PA data cards, and it was completely acceptable. There were no concerns about that practice.
All right. Next question from Suzanne. She wanted to know, where is history of COPD captured? Is it only captured as the PFT results?
Yes. So lung function is captured by your FEV1 and your DLCO.
Okay. I was going to pull up the.
And then I think there are other questions that would perhaps relate to like ECOG status, sort of plays into that a little bit. Trying to think, a preoperative home O2, I would think would home oxygen therapy and the preoperative medication falls into that. Your smoking history potentially plays into COPD. There's a lot of different pieces of the COPD puzzle that I guess that are specifically collected and not as a cohorted diagnosis.
Joanne, is there an official list of participating surgeons in the hospital they work for? No, we don't provide a list or have a list of all the participating surgeons in the associated hospital. Are we allowed to do that? I think the only place where surgeons are in their participating hospital are listed is if they publicly report. And I think it would be posted on the STS public reporting page. I'm just going to go out there to take a look. So yeah, if they publicly report, I'm just going to click on one, but it doesn't list the surgeons, but we don't provide that information. We don't provide that information out. Claudette, seeing the IQVIA resource library, do you need to select a database to see the resource library for that database? So if you participate in more than one database, for example, which I still can't pull it up, but obviously you have access to all 3 databases. But if I were to select, one view, if you went into your adult cardiac site, you would click on adult cardiac, and then you would have access to the library and all information for adult cardiac. Congenital, if you participated in congenital, you would go to the congenital view, select that, and then you would have access to all the congenital only documents. So they are registry database specific.
We can include that in the next user group call, since we got stuck on that one today.
Okay. All right.
I'm gonna do Brenda's question real quick. Are there handouts for AQO? When are those being provided? Do you know offhand, Leanne?
The platform, Carol, do you know when the platform is going live?
We're in your email.
Oh, sorry.
That's okay.
Let's do that. Where is my presentation? There we go. The platform will be going live very soon. All of the content, if you for the presentations will be posted out on the AQO platform. Let me see if there's a link out there yet. And you can print all of that information. I don't think it's gone live yet, but the link will go live and you'll be able to access the presentations, and you can download, you can print and bring those with you beforehand, before AQO. So they will be available before you travel and come to AQO.
And last one, there was a case that was abstracted, 30-day follow-up was completed, and then the pathology report was updated after the case was completed. How would that be audited, essentially, is the question. I do not know the answer to that question, but perhaps Carol does. Or Leanne? No?
I'm rewriting the question. I ran across a case which I had already abstracted and performed a 30-day follow-up on. I looked at the case and noticed the path report was updated after I completed the case. How has this ever happened during an audit? So I think once there's a snapshot taken of the audit data. So once that snapshot's taken, and if that snapshot doesn't match what is what the auditor is looking at, I think there's an update trail that I think the auditor would probably reach out to IQVIA to get like an audit trail of when the data was the record was updated. I think I'm still fairly new to the audit process, so forgive me, I may not be stating things 100% correctly, but Dion, if you want to submit that question, you just want to shoot me an email that question and I'll have Carol review it. But I'm sure it's happened before and there's a process for it. But again, I'm sorry, I'm still kind of new to the audit process from the STS perspective. So it would be, discussed and with the auditor and yourself, and I'm sure you would have a full-on conversation between you and the auditor and would rectify how the case is showing in the snapshot versus what's showing in your database. And so that would be a discussion you would have with the auditor, and you would talk it through it. I don't think they would just go, oh my gosh, this doesn't match, and you're deemed for it. That would be a discussion back and forth, and they would get an updated audit trail, things like that. So I'm not sure if I answered your question, but just submit it to me and I'll have Carol review it, and also I can talk with CRS, our audit company, and see how it's handled. Okay. Do you guys have, please, any other questions? I know it's 4:30 Eastern time. We've made good use of the hour, but please feel free to, let us know your questions. If you think of anything after this webinar, please feel free to shoot me an email. I thought I had my contact information. Yes, my contact information here. Please feel free to shoot me an email. Like I said, anything you think of after the webinar, just email me. Happy to answer your questions. Ruth's email is here, but please, if you have any clinical questions, please submit them via the FAQ. Through that process, don't just email Ruth directly. That we have the process, make sure they go into a FAQ folder. So please, clinical questions, submit via the FAQ clinical question submission process. But again, if you have any other questions, not sure who to contact, what to do, please feel free to reach out to me directly, and I can assist you in any way possible. Well, I don't see any other questions coming in. Thank you everyone for joining today. I hope this was helpful for you all. If you have any ideas of things you'd like to see, we do these new data manager webinars yearly. So if you have ideas on things you'd like to see in our next new data manager webinar series, that would be helpful. Please, give us ideas, let us know. We want to make sure these webinars are useful to you guys and help you in the ways that you need. So please feel free to give us some feedback and let us know some topics that you think would be helpful in next webinars for new data managers. And again, please, if you have any questions, do not hesitate to reach out to us. We're here to help you in any way. We don't want you sitting there struggling and stressing out. Just let us know, and we'll help you any way we can. Thank you so much, Ruth, for presenting today. You're amazing. I appreciate you. And Carol, thanks for joining. And I hope you guys all have a great rest of the week. And for those that will be at AQO next week, I look forward to seeing you again or meeting you for the first time. Thanks, everyone.